at the end, there's going to be several scenarios that we'll talk through. So hopefully it won't be just listening to me talk, but we'll be able to figure these out together.
Are these, Dr. Simmons, did you upload these PowerPoints?
It should be under.
Is it week 6? Week 6?
It might be under week 6 or week 5.
I see. Well, week 5 was only 6 and 23, what we did
Look
today.
at week 6.
So week 6 is, it says chapter 9, and then it says nursing leadership PowerPoint and delegation prioritization PowerPoint.
Delegation and priority setting.
Okay, that's what we're doing first.
Yeah, that other one I saw, for whatever reason, they posted Professor Schofield's course outline. So ignore that one above this one.
The nursing leadership PowerPoint?
Yes.
Okay.
It's her course outline from when she taught the course before. So I'll go in and remove that.
Okay, and then chapter 9, are we going over today?
So chapter 9, probably not. That would be the only thing that we'll discuss. And it's about like time management.
Okay, great. All right, thanks so much.
Yeah, sure. So yeah, this is under week 6, delegation and priority setting. So it is going to review problem solving. And if you remember, we went over these probably the first week. And that is deciding how to handle difficult situations, right? That is problem solving. We have to understand what is causing the problem to even exist. And then we have to have some form of decision making and a step-by-step process to follow in order to hopefully solve the problem. So decision making is part of solving a problem. It's part of that whole process. And what triggers it is an issue has occurred, right? We have a problem in our setting. We have a problem within our facility. We have a problem with a provider. So it's not necessarily focused on eliminating the cause or the problem, but we want to focus on improving the situation, or what can we do better so that we're not having to deal with this particular type of scenario. And then we bring in critical thinking. This is not a new concept to you all. We've been doing critical thinking, and as a nurse, something we do every day in how we take care of patients, how we apply information. We have to analyze the situation in order to get to whatever our answer is. So we have to use a process in critical thinking. We have to reflect on the scenario, the situation. We have to look at the evidence that exists, what research has been done on it, what is the hard facts, what are the practice guidelines surrounding this scenario. Then we have to form some judgments about those facts. We have to use higher order thinking. That's why when you first started nursing school, critical thinking was something you had to practice. It's something that takes skill and development. And in that process, you're using the higher levels of thinking, you're evaluating the situation, and it involves both cognitive components as well as the emotional, the affective component to it. So there's a lot that goes into critical thinking, and we use it just in our nursing care, but we use it when we're solving problems. And as nurse leaders, nurse managers, you have to use critical thinking because things aren't cut and dry. It's not going to be sometimes an easy solution in order to deal with the problems that occur. Delegation is when we assign a task to somebody else, right? So remember, there's a difference between an assignment, like what you get when you show up for work one day and you have beds 4, 5, and 6, patients in bed 4, 5, and 6. That is your assignment for the day. We delegate tasks. And so we're telling somebody else to perform a task in order to accomplish a goal. Who is ultimately responsible for the outcomes of that goal?
Nurse.
The nurse. So even though you're having somebody else, a delegatee, to perform the task, we are ultimately responsible for the outcomes that are going to come from having that task completed. So there's things we have to take into account when we delegate. You can't just delegate every part of patient care. You have to look at who you're delegating to. The person has to be competent. They have to be trained. They have to be knowledgeable about the task. It has to be the correct patient. It has to be the correct situation. But ultimately, the nurse is held accountable. So don't forget, at the end of the task being delegated, we have to evaluate the outcome. So when you look at the nursing process, remember you've got ADPI. What component of ADPI can you delegate?
Implementation?
Yeah, intervention.
Correct. The implementation, the action. That is what can be delegated. And not every action, but some of the actions. So if you ever see something or you're questioning that requires assessment, cannot be delegated. Diagnosis, planning, nope. Evaluation, they can't do any of that. Now, the other thing you have to remember is that you have different levels of subordinates that you delegate to. So it's a bit different if you're delegating tasks to a UAP versus delegating a task to an LPN. So what would be, can somebody give me an example? What is an appropriate task to delegate to an unlicensed assistive personnel? What would just an example be?
Ambulating.
Okay, ambulating a patient. What else?
Assisting a patient with feeding if they don't have like dysphagia or anything.
Right,
That
so
would be hard for them.
yeah, you tied in a critical component to delegating is that it has to be the right patient and the right scenario. So typically UAPs can help patients eat unless there is something that places that patient at a high risk. So if your patient has dysphagia, they're a high risk of choking and aspiration, then that may not be a task that you would want to delegate to a UAP. It should be a task that would be similarly carried out between this patient and that patient and that patient. If it requires any sort of critical thinking, judgment, advanced skill, cannot be delegated. So you have to assess your client, you have to assess the person you're going to delegate to, and then ultimately the situation surrounding it, because there will be circumstances where typically that would be a task delegated. But if it's not, if it doesn't meet all the requirements, then you can't delegate it. Then you plan, you assure accountability, which obviously always falls back onto the registered nurse. You still have to supervise and you have to evaluate. In the planning component of delegation, that is planning ahead. So when you are working, and if you have UAPs that you work with, not everybody has the luxury of having assistants, but if you do, you need to get to know what they're comfortable doing before you need help doing something. You don't want to wait until you are bombarded and need it done right now, and you haven't had the time to really assess your help and assess what they're capable of. So you want to do that before you ever need their assistance. You want to have conversations. Are you comfortable doing X, Y, and Z? I can show you, we can do it together, that type of thing. So always try to plan ahead, get to know the personnel so that when you do need to delegate it, you're delegating to the right person. So there's the 5 rights to delegation, and you want to make sure you understand those. So it has to be the right task. And the circumstance surrounding that has to be right. So we just described maybe the patient who has dysphagia. So that doesn't qualify potentially if they're a high aspiration risk for somebody to help with feeding. Clear communication. So the communication aspect to delegating is really, really important. You can't expect that anybody's going to read your mind or know certain things about a patient or know that you need something done that's time sensitive. So one of the examples I've given you would be about feeding a patient. Can you help the patient in room 303 with their breakfast? If you don't tell the person you're delegating it to that you just administered their insulin and they have to eat within 20 minutes, then they may not get to it within 20 minutes because you didn't give them all the information. So you always want to make sure when you delegate, you give them the entire component so that they know if there's a time circumstance, maybe they can ambulate the patient. But we talked earlier about a patient following a stroke that maybe has like shoulder drop. You cannot pull on the affected extremity. So you would need to relay that information, make sure you don't put any pressure on their left arm or whatever it is. All of that has to be relayed. So clear communication is critical. It has to be the right person. Again, that goes back to what is that person trained to do? What are they capable of doing? What are they comfortable doing? And then the supervision component needs to be there as well, as far as, and that includes the evaluating the end product. So that doesn't mean you're micromanaging the person you've delegated to. It's your responsibility to evaluate if the task was carried out and how the patient is doing. So qualifications for the delegatee, the person you're delegating to, is that they have to have the appropriate education, the skill, and the training. So again, it's different if you're delegating something to an LPN versus a UAP, and we have to know the differences. So as far as what if you don't know what the LPN can do? What are you gonna consult?
Can you ask the question again, please?
Sure. How do we know what an LPN is qualified to do? What are we going to consult to find out what they can do?
Like skills checklist or something?
You may have one at the facility. That's not necessarily what you go off of to delegate, but it is something you could look at to see if they are, if they've been checked off in a particular skill, if that's your organizational's guidelines. But where do we learn what they can do?
The Nurse Practice
Is it
Act.
under the ANA?
The Nurse Practice Act. That is going to tell you what LPNs can do versus what RNs can do, the scope of practice. That is dictated by your Nurse Practice Act. Also, you want to be familiar with their job description. So if you're new on a unit, you would want to get a copy of what is the job description for a UAP? What is the job description of an LPN, to see what is their expectation in their role at this organization. But as far as what a licensed practical nurse can do, you would consult your Nurse Practice Act. You have to make sure they're competent. So like I said, we've discussed blood glucose, and it's determined that UAPs can do blood glucose readings. But what if you have a new hire UAP who's never done it before? They're not potentially trained to do it. They're not competent in doing it. They're still a little unsure. They're not doing it correctly. So we have to ensure that they have been trained. And then how do we determine if somebody's competent in something? What is the best way for us to determine that?
Ask them.
There's like a skills checklist thing that you can review that they've like completed.
So you can talk with them. You can look to see if they have completed their skills checklist.
You observe them.
And you observe them, right? Especially because some things you may be involved with the training, and you'll be with somebody like, oh yeah, yep, I know exactly how to do it. Okay, I want you to do the next one. And they may be like, oh, I'm not comfortable. Return demonstration. Just like, how do we know patients know how to do insulin injection after we've taught them? It's a return demonstration. So
on
make
ATI, like the practice, I want to say that there was one and it said check the skills checklist instead of observing. I think it was doing a catheter or inserting a catheter, if anyone else like remembers more specifically, but that wasn't the answer.
I remember too, like the answer was a checklist, and
Yeah, the
like,
checklist, it
just
said-
ask them.
Yeah,
Was Nurse Practice Act one of them?
no,
Mm.
it wasn't the scope. It was like seeing if an LPN or whatever can
If they're competent.
do, yes. And
So
the
do you
answer
remember what the other choices were?
oof, I would have to go
Okay.
back and look what.
I know one of the choices was like ask them directly.
Oh yeah,
but-
that was another one too.
Well, I mean, you can always see what their comfort level is with something, but that doesn't tell you, because you can ask me and I can say, oh yeah, like I know how to do that and not have any clue how to carry it out. But to get their comfort level, because somebody may see, they could be maybe even have been checked off, but they really haven't done them very frequently. They may not have that comfort level. But your skills checklist typically, and even as a new nurse, you'll probably have to fill one out at a new job. You'll have like a mentor, and you'll have to perform so many of the IV starts before you're checked off to be able to do them by yourself. So that would be evidence that somebody is competent, but you want to make sure they're comfortable with that situation too. I can get checked off on a urinary catheter just like you guys do, right, for skills. But if you went into the hospital, you've been checked off on it, you've talked your way through it, you've done it, would you feel 100% comfortable going right into a room by yourself and doing it? You've been checked off, but are you comfortable? So that's another component to it. But yeah, I would like to see what the other selections were.
I'm trying to find it.
Okay, yeah, just let me know if you see it. But scope of practice should always be the Nurse Practice Act, to see if they're able to even carry that task out or that duty out. That will be important. So delegation issues. Remember, when we delegate, especially as new nurses, it's really difficult to give up that. It's almost like a little bit of a sense of control, because you're responsible. You just went through school, you've worked really hard, you got your license, and it's all kind of riding on your shoulders. And now you're trusting another individual to carry something out, knowing that you're still accountable. So it can lead to under delegating, where the person feels that they have to do it themselves, maybe because they don't trust other individuals, or they might feel that if they don't do their job, they're going to be seen as a slacker or not capable. So they figure, I'll just do it myself. So then you don't end up delegating, and then you end up rushing around. You're not able to complete all the tasks that you have to complete. On the flip side, there are individuals who over delegate. So, you always have to look at what other responsibilities does that person have. And you can't delegate a task to one person on every single person on the entire unit. That's not even reasonable. So you want to make sure that you're looking at their timeline, seeing things from their perspective as well, and making sure that we're only delegating the tasks that we truly need help with to alleviate our list, so that we can focus on things that only an RN can do. I think I gave the example of, you wouldn't want to be delegating to somebody to see if they can go in and change bedding and all that, and then you're just at the nurse's station not doing anything. That isn't okay. You need to be doing an assessment on a new admit, and Mr. Jones, needs to have his bedding and his gown changed. That's appropriate. So we don't want to over delegate. We don't want to under delegate. Part of it could be the competency of the delegatee. We have to make sure that they are competent in these different tasks. It could be a scenario where you only have a couple of new hire UAPs, and they're not really well trained yet. So they just can't perform some of the tasks that you need them to. Being disorganized. At the beginning of your day, when you get report, you're going to have to kind of figure out what are your priorities, which we're going to talk about priority setting, and map out what are the things that you may need help with. When is your busy time looking like it's going to be, and try to get a game plan. Now, things always happen in every shift where you're going to have to readjust, but you want to be as organized as you can. So that way you're planning ahead, and then you are letting people know that you need help in advance, so that it doesn't become an emergency situation. You've probably heard that saying, your lack of preparedness is not my emergency. So we want to be prepared. Things are going to happen. Life happens, especially in healthcare, but we want to try to be as organized as possible.
I found it. And okay. I can do it later if you
don't
want me to interrupt. Okay. And then I have another question that I wanted to ask.
Okay.
So it says a nurse asks a newly hired AP to remove a client's indwelling catheter Which of the following actions should the nurse take to ensure the AP is qualified to perform the task? And it says, show the AP how to remove an indwelling catheter, review the AP's skill competency checklist, ask the AP if they know how to remove an indwelling urinary catheter, or pair the newly hired AP with an experienced AP. And the answer was
The checklist.
review the checklist. Yeah.
And I 100% agree with that. And do you see why it's that one out of your selection?
Well, I know why it wouldn't be the ask,
Correct.
but
Because
that's why
you can
when
say, sure, I can do it.
yeah. And then obviously like pairing a new one up with an old one, I guess, because like the nurse themselves needs to probably see that. I don't know. I wouldn't just take someone like another AP's word for it that they can do it.
It goes
And-
under that remember, we have to supervise, we have to evaluate. So it's still our responsibility. We're accountable for that.
Right. And then show the AP how to remove an indwelling catheter. No, because it's like experimenting kind of on the patient. Like if they didn't know what they're doing, I don't know. I wouldn't just want to do that for the first, I don't know.
Well, because if you go back to what the question's asking, it's ensuring that they're capable of doing it. You can watch me start an IV all day. That doesn't mean you're capable of doing it because you've seen me do it. So what is the best way to?
Oh, yeah, and it's show the AP how to remove. Never mind. Okay.
So that.
So then
it's
the best one of them all.
the same thing where people are like, oh yeah, no, I get it. And then when they go to do it, they have no clue what they're doing. So if you go back to what the question is asking, it's ensuring that they have proven competency or however they worded it. So that I agree with 100%.
Okay, and then one more, just because I felt like some of these questions were kind of tricky, in which they weren't. I would say I'm pretty like good at like communication, and I felt like the correct answers a lot of the times were not the most appropriate way to ask someone to do something for you. You know.
Okay.
But anyways, it says an AP tells a charge nurse that it's unfair that they have to take care of all the clients who are incontinent. Which of the following responses should the charge nurse make? And the answer was, I delegate tasks to personnel based on their job descriptions. And I feel like that's not very therapeutic or anything. The other options were everyone working here has to care for clients who are incontinent, or let's talk about organizing the workflow so you can take care of fewer of these clients, or why do you not want to care for clients who are incontinent? I don't know. I guess I would have just asked why she felt that way. But I wouldn't just be like, I don't know. It just seemed very bossy to me.
Yeah, no, and I get that. And I've seen that there was a couple of things I think that we were going through maybe in one of the case studies where it came across that way as well. But
Yeah.
if you look at, so one of them was like, let's change the workflow. That may not be possible. So that one, is definitely a no-go. The one about, let's see, so you can do less.
Right.
So that one would be, that's not an option.
But I mean, I wouldn't, if someone like, so in a real life scenario, if someone came up to you and didn't like specific tasks, or they felt some type of way about a specific task, like, could you try to, if there was another one, like just even it out maybe to make it more fair? Or no?
So from their standpoint, it may appear as though it's unfair and that's all they get assigned to do. But then you have to look at the other individual, what kinds of tasks are they being assigned, and what's their skill level? How is it different from this individual? So
Okay.
I think probably what you have an issue with, and I understand, is that wording of it being, because they've made it so concise. And I think you can say the same thing, maybe a little bit more elaborate, where it wouldn't come across as being so harsh. And, there are tasks that need to be delegated, and based off of different, what did it say, job functions or job descriptions, there are certain tasks that have to be delegated to certain people.
Yeah. I just feel like no one wants to do stuff for you if you're going to be like kind of
Right.
bossy about it. And then like, because the other one was regarding like effective communication, which is the best effective communication regarding delegation. And the answer was check the urinary output at 11 o'clock for John Doe and report it to me immediately.
Mhm.
And I don't know, the other one's just, I guess it was just the specificness.
So remember, with effective communication, it meets all the criteria, and a lot of that
And
deals
the right patient, okay. All right,
correct.
thank you.
So that's what it was, and it's. I know again, it probably
I just
comes
have to retrain my brain to think of it a different way.
right, because you're not saying I need you to report it to me immediately. You know, it
Yeah.
doesn't have to be in that tone. It's that you've given them the time constraints, the person. You gave them all of the components that are needed with effective communication.
Right.
That's what it's referring to. So
Yeah, not therapeutic communication, I guess, because then that one of the options was like, please notify me or whatever. And so, of course, that's what I wanted to pick.
but also with the please notify, there's probably something else missing. They may not
the name and everything, but so I understood why it was wrong. I just
so kind of try to just alter a little bit your thought process in that what are the elements that are surrounding delegation, the importance of delegation, the safety of it, and not so much, find something. Yeah.
All right. Thank you.
Yeah, sure. You're welcome.
Another thing that helps me eliminate like a lot of the therapeutic communication questions too is if it starts with why, that's like never the answer because it's like confrontational or something. So it always eliminates like one or two of them. So that helps.
And so there are times where we, especially like from patients, right? Like we want to gather more information. You want those open-ended types of questions, but not so much where, like you're saying, where you're coming across as questioning them or being confrontational. But in this circumstance with the effective communication, very different from what therapeutic communication is. And we're looking at really the 5 rights of delegating, so that we're giving all of the necessary information to the person when we need a task carried out. So because you'll probably see questions like that. I would expect that you're going to see which is the best way to, or what is the best evidence of effective communication. It's got to meet all those elements. All right. So step-by-step decision process. So do state rules and regulations support delegation? Does my state and facility permit me to delegate this task? Have I assessed the patient and evaluated their needs? So you have to know your patient so that you can know if it's the right circumstance. You have to assess your UAPs, get to know them. What are their abilities? Is adequate RN supervision available? Because some things do require direct supervision. Would a reasonable, prudent nurse delegate the task in this situation? What is that? Where does this verbiage pertain to? Would a reasonable, prudent nurse delegate the task in this situation? It's from the beginning of the quarter.
Isn't that a nurse?
Standard of care.
The standard of care, and then it goes back to the legality that we talked about. So being held responsible. So is it safe? Is that something that I would be held accountable for? Would somebody else in my position not delegate that task because it basically, or most commonly, is considered not a task to be delegated. So we have to keep that component of it as well. And then have I communicated clearly to the UAP? So going back, know your rights and making sure that we're giving the person all the information that they need. Who's responsible for mistakes that UAPs make? So Shannon's an RN, she delegates a task correctly, but Jordan, the UAP, makes an error that injures the patient. Who is legally responsible? And it goes in to tell you, Jordan, when he accepted the task, became legally responsible for his actions that he takes, but the nurse is accountable for the outcome of the task. The only person in this scenario who's licensed and could be subject really of a lawsuit is who?
The nurse.
Correct.
Unfortunately.
Yep. So don't let the words kind of mesh, get you confused. We are still accountable for the outcome, And so we own a license, and we are the ones who can be brought up in a lawsuit for that, even though the other person shares in that they performed that task. And that's why you have to supervise and evaluate to make sure that things are being done properly. Don't take somebody's word for it. You always need to make sure that you are assessing after the fact, doing that evaluation piece, because that's part of delegating. So you have to make sure it was done and it was done correctly, because you're responsible. You know you're making a sound delegation decision when you assign a competent UAP a simple task not requiring nursing judgment in a predictable patient context. So again, the task that needs to be carried out should not be different, very different from person to person to person. It should be something that would be done the same way on multiple patients. It's not requiring them to use judgment, a bunch of critical thinking. They're not able to do that. And then it has to be the implementation piece of it. So patient assessment, initial patient assessment. Whose responsibility is that?
The nurse.
Absolutely. What about even if an LPN?
No.
No.
Correct. Triaging patients.
A nurse.
Correct. IV push medications.
Nurse.
A nurse.
Irrigation of a catheter.
Nurse.
Teaching. Discharge teaching. Nurse. Monitoring wound progress.
Nurse.
Heparin flush.
Nurse. In the
So
book,
think
it
about-
did say, in the ATI book, it did say that in some states, LPNs are able to do IV push meds.
Not narcotics though, usually.
No, not narcotics, but like a heparin flush and stuff, or
Yeah, so they can push certain medications, but definitely not narcotics. But typically, like assessment, they can do like reinforcement education. So that would be like teaching new diabetics foot care, no, but they could reinforce the teaching that has occurred. They could probably do the heparin flush. They could irrigate the catheter. But assessment, all that would have to be the RN. And then, yes,
About LPN. So since they can't do assessments, what about if they're about to administer like a blood pressure med? And do they still like take the blood pressure, determine if they're going to give the med, because there's like obvious stated parameters? That's not really an assessment.
so if they are, yes, so with, because they can do vital signs and they can look at the blood pressure and see if it meets the criteria for that blood pressure pill. So that is fine for them.
So one more thing also, like, so when we're at John Knox for Gero,
Mhm.
like we watched a dressing change, like the LPN did the dressing change of a wound vac of a pressure injury. I mean, there's no other person there to like see the progress of the wound.
So the assessment of the wound probably still needs to be done by the registered nurse, but if they're just doing a dressing change of it, then the LPN should have the ability to do that.
Okay.
Mm-hmm. Yep. So prioritization, and we've done a lot of prioritization, even just in the exams that we've talked about. Med surge was a big one where you had to, what is the priority intervention? And so you have to determine, you know, when you get report at the start of your shift, you have to attend to every patient, but somebody is going to need to be seen first. And so you have to determine who is most critical or needs your attention immediately versus the other patient or patients who could wait until you see the more urgent ones. So you've really got to have all the information. So that's why like good report in the morning or when you get on shift is super important, because you have to understand their entire picture regarding that patient. And then you have to understand what could happen if certain interventions aren't carried out or why certain interventions are critical. So it's really tying everything you've learned in together, and you are prioritizing all day, every day. You're not doing it in the way that you do on an exam, but you're really doing it every day that you're a nurse. So we look for who's critical, right? So one of the things I always told you guys, like when you're answering these questions, is something going to kill your patient? Probably what you need to be doing first. Or is it going to hurt your patient? That's probably going to take priority. So ask yourself that when you're thinking about prioritization. If I don't go see this patient right now, is there something that is either going to cause a life-threatening circumstance, or could it end up causing patient harm? Those are things that are going to take priority. Is the task essential to patient or staff safety? And is it essential to the medical or nursing plan of care? So that is what you kind of have to go through in determining if something is deemed critical or if it can wait until you've seen some other patients. So 3 levels of patient status. You guys know one of the first things we do is ABC. We have to assess their airway, their breathing, and their circulation. Then we also look at vital signs, right? We look at mental changes, mental status changes. Sometimes that's the first indicator that a patient is going south or the patient is having a complication. Acute pain, acute elimination problems, abnormal labs, and then health problems that don't fit into the first 2 levels. So do they have long-term health issues? Do they need health education? Are they not coping well? We focus on Maslow's hierarchy of needs, and then the nursing process, your ADPI. So always think about those things when you're trying to prioritize your patient care or even your nursing interventions as to which one needs to be done first. So we're going to go through some scenarios. The nurse hears in inter-shift report that a client receiving TPN at 100 mils per hour has bilateral crackles and 1+ pedal edema. When the nurse obtains a daily weight, the nurse notes that the client has gained 4 pounds in 2 days. Which nursing action should the nurse take first? Encourage them to cough and deep breathe. Compare the INO records for the last 2 days. Slow the PN infusion rate to 50 mLs per hour. Administer the prescribed daily diuretic and check the client in 2 hours.
I would say 2.
To compare the INO records of the last 2 days. Okay. And why would you pick that?
Because it's an assessment and it's asking what you should do first.
Okay. Anyone else thinking something different, and why? And it's okay if you're wrong. You want to start getting into the thought process.
I kind of think it's 4.
Administer the daily diuretic and then check them in 2 hours.
I was thinking it might be.
I would encourage the client to cough and deep breathe because was on our sim and seemed to be the proper action. So it's really respiratory and circulation. So first I want to get them oxygenated. So my first step would be a respiratory intervention.
Okay.
I would say 2, just so you can see like in more detail, like the weight gain.
Okay.
Like if it's a fluid imbalance or something.
Okay. So when you pick something, always have a rationale, have a reason as to why you're picking that. May not always be right, but you should be able to back it up. Like, I am selecting this because I feel this is most important because of whatever. So it's actually answer 2. They are already showing signs of fluid retention, possible excess fluid. They've got the crackles. They have the 1+ or 2+ pedal edema. They have the weight gain. It's already been noted, right? So noting the client's INO records adds to the database of information, which should then be reported. The problem may not be related to the PM that's infusing. So it could be that the patient's having a respiratory issue, or it could be that the patient's gone into a cardiac problem or renal failure. So then the RN gives an inaccurate dose of a medication to a client. Following an assessment of the client, the nurse completes an incident report. The RN notifies the nursing supervisor of the medication error and calls the physician to report the occurrence. The nurse who administered the inaccurate medication dose understands that the error will result in suspension. Incident will be reported to the Board of Nursing. The incident will be documented in the personnel file. The incident report is a method of promoting quality care and risk management.
4.
4.
4.
Anybody think it's anything other than 4? And that is correct. So if you make a mistake or you have an incident like that, it does need to be reported, but the whole premise of reporting it is to try to not have it happen again, right? To make sure that we're tracking these things so that patients stay safe. Not that it's going to go in your personnel file and when you get a new job, they're going to be able to see that you gave an incorrect medication. That's not the purpose of it. The RN has been caring for a terminally ill client. The RN has developed a close relationship with the family of the client. Which nursing intervention will the RN avoid in dealing with the family during this difficult time? Making decisions for the family, encouraging family discussion of feelings, accepting the family's expressions of anger, facilitating the use of spiritual practices identified by the family.
1.
1.
Good. So you're supportive, you're going to advocate, you're going to assist them with resources, but you're going to, and I'm telling you, you will be asked more times than you can count. What would you do? We don't give them those decisions. We don't make decisions for them. We just give them the information and the support that they need to make a decision. Hospitalized client tells the RN that a living will is being prepared and that the lawyer will be bringing the will to the hospital today for witness signatures. The client asks the RN for assistance in obtaining a witness to the will. What is the most appropriate response to the client? I will sign as a witness to your signature. You will need to find a witness on your own. Whoever is available at the time will sign as a witness for you. I will call the nursing supervisor to seek assistance regarding your request.
4.
Anything other than 4? Good, that is correct. RN's caring for a client with severe cardiac disease. While caring for the client, the nurse states, if anything should happen to me, please make sure that the doctors do not try to push on my chest and revive me. What is the most appropriate nursing action? Tell the client and the family must agree with the request. Plan a client conference with the nursing staff to share the client's request. Tell the client that it is necessary to notify the physician of their request. Tell the client that this procedure cannot legally be refused by the client if the physician believes that it's necessary to save their life.
3.
3.
And I think you all have seen that before. Correct. Client brought to the emergency department is dead on arrival. The family of the client tells the physician that the client had terminal cancer. The emergency department physician examines the client and asks the RN to contact the medical examiner regarding an autopsy. The family of the client tells the RN that they do not want an autopsy performed. Which response to the family is most appropriate? An autopsy is mandatory for any client who is DOA. The decision is made by the medical examiner. I will contact the medical examiner regarding your request. It is required by federal law. Why don't we talk about it and why don't you tell me how you feel?
3.
I would go with 3. Only because 4, I don't know if it's required by federal law.
Okay. I haven't seen these before, so emergency department physician examines the client and asks the RN to contact the ME.
Is it required by federal law?
Because they died outside of the facility. It's required by state law in certain circumstances, including sudden death of a client and death that occurs under suspicious circumstances. The client may have provided oral or written instructions regarding an autopsy if an autopsy is not required by law. So I guess it varies by state. Then the oral or written requests will be granted. If no oral or written requests were provided, state law determines who has the authority to consent for an autopsy. Most often, the decision rests with the surviving relative or next of kin. So notifying the ME. Client with a perforated gastric ulcer who is scheduled for emergency surgery cannot sign the operative consent because of sedation with opioid analgesics. The nurse takes which priority action? Obtains a court order, sends the client to surgery without the consent form being signed, has the hospital chaplain sign the consent, obtains a telephone consent from the family member witnessed by 2 persons.
4.
Or
It may be 2, and
Yep.
why would it
Yep.
may be 2?
I'm saying it's implied consent.
It falls under
Because
implied.
it's an emergency.
Correct. So it doesn't state that the surgeon is invoking implied consent. So the answer here is 4. I don't agree with that. This would be an instance of implied consent. So it's emergency surgery, the patient sedated, or we talked about this earlier, patient comes in unconscious. You do not have to get family permission. The surgeon can invoke implied consent. And then they have to document it. It has to be fully documented in the chart. So I don't agree with that one. Every effort must be made to obtain permission from a responsible family member to perform surgery. But here's the thing. They're holding up surgery, trying to reach family members to get consent. So yeah, so the client may be unable to sign and family members may not be available. In this type of situation, the physician is legally permitted to perform the surgery without consent. It's implied consent. That to me is your best response. The preoperative client expresses anxiety to the nurse about the upcoming surgery. Which statement by the nurse is most likely to stimulate further discussion between the client and the nurse? So they're anxious and we want further discussion. If it's any help, everyone is nervous before surgery. I will be happy to explain the entire surgical procedure to you. Can you share with me what you've been told about your surgery? Let me tell you about the care you'll receive after surgery and the amount of pain you can anticipate.
3.
3.
Good, yeah. The nurse has a prescription to give 30 mLs of an antacid to a client through a feeding tube. Which is the priority nursing action? Assess tube placement, administer the antacid by gravity flow, aspirate to determine residual volume, follow medication administration with 30 mLs of sterile saline.
3.
I think it's 3.
One.
Would you say 1? 1 or
I'm
I
21.
go with 1 for some reason. That came up on one of the tests too.
correct? So it goes back to this one does follow the nursing process, but also you always assess tube placement. You do need to usually assess residual volume before using it, but the most important thing is that you make sure the tube is in the right location.
How do you
So
tube
when we're,
placement, like when you're about to go give meds?
Say that again.
How do you assess for tube placement before you give meds?
So typically you listen for the, are they still having you all inject air and you listen with
Air.
the stethoscope?
yeah,
Yeah.
And then you'll follow it probably with checking for the residual volume, but you usually put air into a syringe, inject it, and you've got your stethoscope, and you should hear it in the stomach.
So when we talk about a feeding tube, what are we talking about? Are we talking about like a GI, like
Probably an NG tube or an OG tube.
Okay. So not one of those like.
Gero, I actually did one that was an ostomy. I mean a G tube.
Yeah.
He had me put air in it, even though it was a G tube. He wanted me to shoot the air or liquid. It wasn't air. I put in fluid and listened. That was the instructions I was given.
And it was a peg tube?
So it wasn't air. It was saline or it was water.
Okay.
We got water from one of the humidifiers, air humidifiers, to use sterile water.
Okay. And that was like a peg tube? Going right into the gastrostomy tube, right into the abdomen?
Yes.
Okay.
And it's really hard to hear because I couldn't really tell which were movements, bowel movements versus injecting the fluid. And so he just said, all right, no problem.
Yeah.
But it's hard to differentiate between normal bowel sounds and while you're injecting this stuff.
Right. So it's anatomy, making sure that you're actually over the stomach and not over the intestines, and it should correlate to as you're pushing the fluid. So a couple of different elements there that you would have to try to hear as you're doing it. Which client would the emergency department triage? Which client would the emergency department triage nurse classify as emergent? Client with a displaced fracture, client with a temperature of 101, a client with a simple laceration and soft tissue injury, a client with crushing substernal pain who is short of breath.
4.
Good.
There was a question on ATI also that I had forgotten about. What is it, like red, like the different colored bracelets in like an emergency room? Isn't red is not like, doesn't have a good chance for survival, right? And then like green is something, I don't know. I remember learning that, but I chose the one, it was like 4 breaths per minute and like a serious head trauma basically. But then I guess it was a chest wound, and the client was a sucking chest wound or whatever.
Okay.
And I guess you wouldn't do the one with 4 breaths per minute because they don't have a good outcome anyways.
So was that in disaster triage?
Yeah.
Okay, yeah. So remember, disaster triage will be different from
Like in a
hospital.
Okay.
Yeah.
I just remembered, I think we learned about different colored bracelets or something. Red was not good. There was like a yellow.
No, it was black. Black was not good.
Okay.
The red
Then
one was
most
emergent.
critical.
Oh, I thought black was already deceased, or black is they're not going to make it.
I don't
Yeah,
remember.
black one was hopeless case.
And then what was the red? Just like critical?
The critical, urgent one.
The most critical.
But that was disaster scene grading patients, like
Yeah.
the doctor said.
Yeah, ED
I
triage.
don't see that in the ED unless somebody disagrees.
No, but I thought it was like an emergency.
It is, but we did discuss disaster triage versus emergency department triage. So they're different. So in regular triage, you're going to do everything you can for that one individual. In a disaster situation, you probably have mass casualty. And so that's when they're going to need to mark who has the greatest. I think I shared with you guys the story of a bombing where the little girl came out, she was still breathing, but due to her injuries, she was not going to make it. She was still technically alive at that point, and the doctor had to make the decision to not use any resources on her because her prognosis was she wasn't going to survive. And the bystanders got really upset by it. But you can't use resources in a mass casualty disaster event like that on somebody who has a very slim chance of surviving. You have to use them for the greater good, which is difficult for somebody to make that decision. But Just a couple more. The nurse manager meets with the staff nurse and announces that management has developed a new policy and procedure that is significantly different from old practices. Which statement, if made by the nurse manager, would reflect the manager's use of legitimate power? The healthcare system services a client population that presents particular challenges. These changes made will enhance client safety and reduce errors. If you don't follow the new policy and procedure, I'll have no choice but to give you a notice about poor performance, which could lead to termination of your employment. Every manager has the responsibility to see that these new policies and procedures are followed 100% of the time. Please join me in this organization's effort to continue to improve quality care. You're just going to have to trust me on this one. I was a member of the committee that wrote the policy and procedure, and these are good reasons why the specific nursing actions need to be done this way. Which statement would reflect the manager's use of legitimate power?
One.
Yeah, one.
Okay. Every manager has a responsibility to see that these new policies and procedures are followed 100% of the time. Please join me. Safety and reduce errors. It's saying it's 3. Legitimate
Yeah,
power.
because it's from that management, manager versus leader. They talk about the manager having the responsibility. So I think 3 is correct based on that particular chapter, chapter 3.
And so it's based upon a person's position within an organization or society. So it's exactly what Uma just said. The organizational leadership has mandated performance outcomes, and management carries the responsibility to see that the mandate is met. So that is correct. Good job, Uma. For which of the following client situations would a consultation with a rapid response team be most appropriate? 45-year-old, 2 years after kidney transplant, second hospital day for treatment of pneumonia, no urine output for 6 hours, temp of 101.4, 98 heart rate, 20 respiration, 168/94. Then a 72-year-old, 24 hours after removal of a chest tube that was used to drain pleural effusion, 97.8 temp, heart rate of 92, respirations 28, blood pressure 136/86, and they're anxious about going home. 56-year-old, fourth hospital day after cabbage, sore chest, pain with walking, 97 temp, 84 heart rate, 22 respiration, blood pressure 122/78. He's bored. And then an 86-year-old, 48 hours after post-op repair of a fractured hip, nail was inserted, alert oriented using PCA pump, temp 96.8, 60 heart rate, 16 breaths per minute, 120/82, talking with their daughter.
I would go with one.
And what makes you choose 1?
No urine output. He has a fever. His blood pressure's up.
Everyone else looked pretty stable to you based off what they had?
Yeah, especially it says anxious or bored or like talking
Yeah,
with
one's
other-
bored, the other one's talking.
Right. So keep this in mind as you go into ATIs as well. What is normal for that patient based off of their diagnosis or what they've had done? Kind of spoke about that earlier. It may not be a normal finding, but is it normal for this patient under this circumstance versus is this a sign that something could be happening? What are we worried about with number 1?
Also, the way I looked at it is what the
projecting.
responsibility is, rapid responses, and what they would or would not be able to correct. And it seems that in 1, they would have more of an authority to be able to do that kind of treatment,
Isn't it like
correct those
rejecting
problems.
Isn't it what?
like rejecting the kidney transplant? Like it could be having like an adverse.
Yep, even though it's 2 years after, it is possible, because remember, transplant rejection doesn't have to happen immediately. You're not seeing urine output, you're seeing an increase in the body temperature, blood pressure is up, so it could be evidence. Yep. And so rapid response is a critical patient, could be coding soon. That's when you're going to call a rapid. The other ones were pretty stable. Sorry that the one individual was forward.
The other way I looked at it is those are things that as a nurse I could take care of, whereas I would need assistance on the other, since it was seemingly an emergent situation that I
Right.
might not have been able to correct on my own. And
Right.
that's when I call the RRT.
More hands on deck. Absolutely. From the following list of nursing activities, select those that the RN can delegate to the LPN or licensed vocational nurse. Select all that apply. So what you can delegate to an LPN or LVN.
2, 3.
I will say in most circumstances, even though we talked about certain places may allow certain things to be IV push, that usually is reserved for the RN.
Can they give injections?
Uh-huh.
5, 6. All right, so 2, 3, 5, 6.
Anyone think it's anything different?
So they can do catheters.
Mm-hmm. Yep, they should be able to do urinary catheters, which is a sterile procedure, as
And
is
trach, right? Yeah, trach sectioning.
that's sterile as well.
Yeah, I agree with that with Melissa.
I would, and I don't know what the next one is, especially because you guys made me lecture without preparing. Just kidding. But I do not think that IV push meds would be on that list. Yeah, so it shouldn't be. So in most circumstances, I would go with that's a no-go for LPNs. So it says oral, sub-Q, IM, and some piggyback medications is what they can administer. And then also remember, if you're given, because this was something I think some of you missed before, if you have a team, so you have an LPN and 2 UAPs, you have to think about what you're delegating to who, right? So we're needing to delegate so we can do stuff that only the RN can do, right? So don't give the LPN something that a UAP could be doing, because we got to divvy it up appropriately based off of their scopes of practice. So if you need a urinary catheter, then that's what needs to go to the LPN, and let feeding go to the UAP. So make sure you're looking at who it's being delegated to if you get a question about that, because that's going to be a big difference. You want to utilize your resources that you have available the best that you can and delegate to the right person. Otherwise, you're going to tie up an LPN doing something that the AP could have done. So just something to keep in mind. All right, hopefully that was helpful. So what we'll do, Friday, your exam is at 1:30. I haven't done it yet. I have no idea how long it will last, but what I'm kind of thinking of doing is allowing a bit of time. The majority of you should be able to get home. And then all we have to do is meet, and we'll cover the time management section in chapter 9. It should be a pretty quick lecture communication part of it. I'll answer any questions that you have. So if that is agreeable, I'll just allow additional time following the exam so that most of you can make it home before the lecture starts. Any questions? Any questions, comments?
So the review is tomorrow, correct, at 1? Or is it next Thursday?
So it's tomorrow. The Med-Surg content review is every Thursday from 1 to 2. I know your Med-Surg ATI is next Wednesday. So this week I'll be reviewing some of the stuff from cardiac respiratory, and then we focused on GI. So those would be like the 3 topics. We'll do practice questions, so it may be good for some of you to hear it. When we get done, I'll email you as a cohort the link to it's a different Teams meeting. I'll email you the link. If you're not going to be able to attend it, but you want to watch the video, then respond back to me so that I can add you specifically to the team. And then hopefully you'll have access to the video, because otherwise I don't think you do. So just make sure you let me know. So that is tomorrow at 1 o'clock, and it's for an hour.